All right. So we are right at the 12 o'clock hour. Good afternoon, everyone. My name is Ellen Dunn. I am the program director and social worker here at Alzheimer's Services. Thank y'all so much for joining us here today for our May Lunch and Learn. We have a really awesome topic today and a really wonderful speaker. So I want to go ahead and just dive in. But first, just a couple of housekeeping announcements. After the presentation, I'll be sending out a follow-up email that will have a survey in it. If you guys could just complete the survey, that just helps myself, it helps Elaine to just know what you enjoyed, what we could improve for the future. And then also too, we'll also send a PDF copy of the slides as well. So in case you would like to review them or share them, you'll have access to that too. I'm going to go ahead and just introduce our speaker for today. Today we have Elaine Maccio. Elaine earned her MSW in 1998 and PhD in social welfare in 2004 from the University at Buffalo, the State University of New York. Dr. Maccio joined the faculty at the LSU School of Social Work in 2006, where she is now Associate Director, Associate Professor, and MSW Program Director. Dr. Maccio's research interest is LGBTQ plus runaway and homeless youth, on which she co-authored the forthcoming book, LGBTQ Runaway and Homeless Youth, A Guide to Practice, Policy, and Research. Her teaching interests are similar, leading her in 2014 to develop the undergraduate LGBTQ studies minor, the first at LSU and the only in the state of Louisiana. She is engaging locally and nationally in several ways, including having founded the Baton Rouge Equality March in 2012 and serving as a member of the Council on Sexual Orientation and Gender Identity and Expression of the National Accrediting Body for Social Work Programs, the Council on Social Work Education. Dr. Maccio lives in Baton Rouge with her wife, Dr. Sherry DeSalle, a psychologist in private practice, and their dog, Jackie. Thank you so much for joining us here today, Dr. Maccio. I'm going to let you take it from here.
Great. Thank you so much, Ellen. And thank you everyone for being here today. It really is a privilege to be back. It's been a few years since I have done a lunch and learn with Alzheimer's Services, and I'm really grateful to be here with all of you. So thank you for joining me on your lunch hour. I hope you have something good to eat. As we go through our presentation today, I look forward to taking your questions at the end. To get started, I'm going to show a screen that has QR codes, so get your phone ready. The QR codes lead you to the PowerPoint presentations. So here we go. Let's see, maybe. There we go. Okay, so the QR code on the left will give you a PDF with one slide per page. The QR code on the right will give you a PDF with 2 slides per page. So give you just a couple seconds to take shots of those. If you don't have your phone handy, what you can do is you can take a screenshot, which on your keyboard usually says something like print screen. And then you can paste that image on a Word document and take a picture of it later, in case you don't have your phone right with you. All right, so we're going to move on in 3, 2, 1. Good, great. So today we're going to go over 4 primary themes. The first is on terminology, just to make sure that we're all on the same page. The second is to just give a brief overview of the diagnostic criteria for the dementias out of the latest DSM, which is DSM-5-TR, which is text revision, which was published last year, and that replaces DSM-5, which was published in 2013. Then we'll go over some of the unique needs and experiences of this population, and then we will wrap up with some practice recommendations for professionals and some resources for professionals and people affected and their caregivers. All right, so let's start with some terminology. And in full disclosure, I have to say that I get a lot of the latest updates from my students. So they keep me on my toes and let me know when I get something wrong, which is good. They also keep me abreast of what the latest terminology is. Now, that said, definitions do change quite often. And this is actually a disclaimer I give in class as well, because I will undoubtedly say something wrong because the language changes so frequently. I might use terms that have fallen out of favor. So there's that. Plus, I'm going to give you definitions here that maybe not everyone adheres to. So some people might use terms in a way that means something different for them. So just know that lots of things with regard to language and terminology are subjective and frequently changing. All right, so let's start off with sexuality. First, let's talk about sexual orientation. Sexual orientation is one's sexual thoughts, feelings, and seemingly explosions here. That's actually supposed to be behaviors. Sexual thoughts, feelings, behaviors make up one's sexual orientation. Usually people think of it just as attraction or behavior, but we can think of it a little bit more broadly in terms of thoughts, feelings, and behaviors. Sexual identity, on the other hand, is just a label that we give ourselves. So usually sexual orientation matches one's sexual identity, but for example, if someone is not out, then they might have a sexual identity that is different than their sexual orientation, especially if someone is trying to pass as heterosexual, the label, when in fact their sexual orientation might tell us something different. So some terms for sexual orientation the direction of sexual orientation refers to having sexual thoughts, feelings, and behaviors towards the opposite sex. And opposite, I use assuming there are only two genders, because our understanding is now that there are more than two genders. But for the sake of ease, I'm saying opposite gender, same sex gender, both sexes or genders, again, assuming that there's only two, multiple sexes or genders, or no sexes or genders at all. Sexual identity, on the other hand, are the terms like heterosexual or straight, or lesbian, gay, bisexual, or queer, or aromantic. Aromantic folks are those who don't feel that they have a romantic connection to someone. Asexual people are those who feel that they don't have a sexual orientation. Aro-ace is a combination. Some asexual people are also aromantic. However, some aromantic folks may engage in sex. Some asexual people may engage in sex. So it really varies on a continuum. Pansexual and the lesser used omnisexual refers to people who are attracted to others regardless of sex or gender. So these are folks who could be attracted to men, women, transgender people, genderqueer people, those who are asexual. So it's not really limited to a sex or a gender. And then those who identify as demisexual are those who are attracted only to those for whom they have developed a romantic attraction, a romantic relationship. Something that helps explain the difference between sex and gender is the gender unicorn. This replaces the genderbread person because the gender unicorn is more inclusive of gender and expression on a continuum. So instead of just male, female, it's more inclusive. So let's talk about gender then. We have the gender identity, which again, like sexual identity, is just a label. It's the term we use for ourselves. And then there's gender expression, how we do gender. So gender expression can come out in the way we dress, clothes we wear, whether or not we wear makeup, how we wear our hair, and whether or not we run, apparently. Actually, that's supposed to be mannerisms. So the way we perform or express ourselves in public usually is how we consider gender expression. So the different identities that people can adopt for themselves with regard to gender are cisgender. The easiest way to explain this is people who are not transgender or not non-binary, so cisgender. Then we have folks who are transgender, those whose the sex they were assigned at birth does not match the gender with which they identify. Then we have non-binary, which covers a lot of different identities, such as genderqueer, of which androgynous can be a part, or sometimes people see them as interchangeable. Demi-guy or demi-boy and demi-girl, bigender, pangender, trans-feminine, trans-masculine, agender, or neutrois or neutroi, androgynous or androgyne. So demi-guy, demi-boy, or demi-girl are those, let's say demi-girl, someone whose gender was assigned female at birth, but maybe only somewhat or slightly identifies with the feminine side of that gender. Bigender is someone who feels that they embody more than one gender. So it could be both male and female, or it could be male and some other gender. Pangender is someone who feels that they embody multiple genders. Transfeminine, transmasculine, these are transgender folks who maybe don't identify as man or woman. So for example, a transmasculine individual is someone who's transgender who feels more masculine than feminine, but may not refer to themselves as a trans man. Agender and neutrois or neutroi, these are folks who don't embrace any gender, feel that they don't have a gender. The difference between the two is that the neutrois or neutroi, it's pronounced both ways, folks experience some kind of dysphoria about the fact that they feel that they don't have a gender. And then androgynous or androgyne, again, sometimes gets used interchangeably with genderqueer, but it could be folks who feel that they embody a little bit of both, male and female, or some other gender. And then gender expression is typically done as feminine or masculine or both or neither or somewhere on a spectrum in between. All right, so I'll blow your mind a little bit more. What if I told you that people can identify their gender in a fluid way? So in other words, this is somebody who identifies as gender fluid, experiences changes in their gender over time. So over a matter of hours, days, weeks, months, years, the person might float between feminine or masculine or neither or both. So it changes over time. And then there's a term called gender flex, which is when individuals experience their gender in varying intensities. So maybe identifying as male and at some points in time, really embracing or identifying more with that masculine side of them than at other times. So gender has multiple dimensions to it in terms of how somebody feels internally, the way they express themselves, the label they give themselves, and then again how they experience their gender over time and intensity. Okay, not everybody's a fan of the transgender umbrella, but again, for sake of ease, this is one way to explain the transgender gender identity. So we can think of it in terms of binary gender and non-binary gender. So binary gender, it is self-explanatory. The person is either male or female. So trans man or trans woman. Then a lot of those identities that I just talked about a minute ago would fall under the non-binary. So all the different ways there are to be transgender in a non-binary kind of way. So genderqueer, demigirl, agender, And again, pangender, all of the ways that I talked about in the previous slide. So I know this is a lot of information that I'm cramming in a very short period of time. So just bear with me. I'm not expecting everybody to know this. It took me years to get this down, and I still make mistakes. So just hang in there. It will all make sense in the end. All right. So again, we refer to transgender people as either trans women or trans men. And again, this represents an incongruence between the gender they were assigned at birth based on their sex, their physical presence, their reproductive organs and genitalia, and the internal experience of their gender. So if they were assigned a male at birth, a boy, but then as they grow up, they realize that they don't feel like a boy, that they don't experience the world like a boy, that they lean more towards, or that they feel absolutely as a girl. So it's that incongruence. Some people, probably most folks who experience this incongruence, will also experience gender dysphoria. So dysphoria means distress. So distress about the fact that the gender they were assigned at birth does not match the gender with which they identify. Yeah, it's the dysphoria that will lead folks to transition, which we'll talk about in just a moment. There are no real clear prevalence estimates. Back in the mid-90s, there was a study done over in Europe that estimated that 1 out of every 11,900 males born would later identify as trans women, and 1 out of every 30,400 girls born would later identify as trans men. So it's more common in boys, so male to female transitioning, than it is female to male transitioning. A little more recent has slightly different numbers. Again, they vary anywhere from 7,000 to 20,000 in trans women, which is still more common than the 30,000 to 50,000 in trans men. I'm going to give you a moment to read this quote from somebody who identifies as transgender and experiences gender dysphoria. So, with all of the anti-trans bills that are going around right now, this is kind of what's at stake, is people who just do not feel at home in their bodies, that this causes great psychological pain. And so gender affirming care then is something that is medically necessary to alleviate that pain. So a little bit about transgender. Here's the transitioning piece that I was referring to. There's social transitioning. So for example, somebody might start off by changing their name and their pronouns. And then they may go on to changing their appearance, like their clothing, or the way they wear their hair, or the way they carry themselves. And then there's physical transitioning, and this involves possibly taking hormones or undergoing aesthetic procedures such as electrolysis, which is permanent hair removal, or body contouring. And then there's surgery, which not every transgender person opts for. It's invasive, it's painful, it's a major undertaking, and it's expensive, and a lot of it is not paid for by insurance. I'm not going to go over these in detail just for the sake of time, but you have these to look at on your own or to look up. So for trans women, these are the different types of procedures that they may opt to have. And the left column is aesthetic options. Top surgery is having a breast augmentation, or having mass added to their breasts on top of what estrogen would give them. And then there's bottom surgery, And then for trans men, here's a list on the left of aesthetic procedures that they might undergo. Top surgery involves obviously a double mastectomy followed by chest reconstruction, and then a host of possible bottom surgery options. I encourage folks to avail themselves of this wonderful resource by WPATH, which is the World Professional Association of Transgender Health. They publish a standards of care, and they actually just came out with a new one, I think last year, they're maybe the year before. They're on version 8. And I'm not going to go over these credentials either, but you have them here. This is not to say you have to have this in order to treat folks who identify as transgender. This is just their recommendation for best practice with trans folks. So if you Google WPATH, you will get to their website and you can download that those standards of care, the document. Okay, so quickly, what not to say to people. Yeah, don't say sexual preference, because obviously it denotes choice in one's sexuality. We don't use the word homosexual really much anymore. It's antiquated, it's associated with pathology. Lifestyle, don't really know what that means to have a gay lifestyle, or an LGBTQ lifestyle, or a trans lifestyle. We don't use the word transsexual anymore. We used to refer to those transgender people who had undergone transition. However, we just use the word transgender. Some folks do choose to use transsexual for themselves. In that case, you would use the word transsexual. Otherwise, we don't use it. Don't add an ED to the end of transgender. It's not a verb. It's not like, what happened to Bob? I don't know. One day he was fine. The next day he was transgendered. It's like nothing happened to the person. So we don't say a transgendered person. We just say transgender. And don't use the word preferred when talking about someone's pronouns. They're not pronouns that they prefer, as if we have a choice. They are the person's pronouns. So we would say, you know, what are your pronouns, or what pronouns do you use? Not what pronouns do you prefer, or what name do you prefer? It's really just what name do you go by? Another topic I'm not going to spend a lot of time on here is intersex and the many intersex conditions. Sometimes you see I added on to the end of LGBTQ, with or without intersex people's permission. They get added to LGBTQ. But here are some of the more common conditions that fall under the intersex umbrella. On the right is the intersex pride flag, the pride symbol, which is a yellow background with a purple circle. And so intersex refers to either malformed or absent, or an overproduction of any combination of hormones. It could be due to genetics, and results in ambiguous, again, or absent genitalia, reproductive organs, or other physical features. Okay, so let's take a 30,000 foot view, or maybe even a 15,000 foot view of some of the diagnostic criteria in the latest DSM here, the Diagnostic and Statistical Manual of Mental Disorders. So first, let's talk about how a diagnosis is put together. In other words, what are the words, what are the domains in these really long terms? So the first is whether or not a dementia is major or minor, and this refers to the degree of decline, usually cognitive decline. The second piece, for some, maybe about half, or maybe just more than half of the dementias, is whether or not the cause is possibly due to, or probably due to, an underlying condition. Next is the condition, the actual underlying cause or the type of dementia that a person has. And then lastly, we add on some specifiers to the end, and these specifiers refer to the severity and any features associated with that particular diagnosis. So for example, let's start with major and mild here. So major and mild is part of a diagnosis that all dementias share. So a diagnosis will always start out with major or mild. So the criterion that they all share is evidence of significant if it's major, or modest if it's minor, cognitive decline in one or more cognitive domains, and the cognitive domains are different for each type, based on both a concern of the individual or an informant, such as a family member or a clinician who is seeing the individual, and cognitive impairment that's been verified by testing or some other qualified assessment. And then the secondary criterion. So A is the first, is the primary criterion. B is the secondary criterion. That deficits either interfere for major or do not interfere, minor, with independence in everyday activities. So these are not the only two criteria for major and mild. There are a couple other rule out categories, like ruling out delirium, I think maybe is one. But these are the two primary ones. So here's a summary then. So major indicates that the individual is exhibiting significant decline that interfering with their independence. Minor is a modest decline, not interfering with their independence. So there's an art behind the science. There's a subtlety here in distinguishing between significant and modest, and the DSM will give you clues as to what constitutes significant versus modest. Okay, so the next on the list then is whether it's possible or probable. I really summarize, I really just simplified and summarized these. Obviously, you can't use what I have here to make a diagnosis. Again, it's just this 15,000-foot view. What I've put here is what makes a type probable. So I don't have anything here about what's possible. And also there's some subtleties in some of these as well. So for example, with Lewy bodies, it's not just one of those, it's two or one plus one of the suggestive criteria. So it's a little bit more complex than this. But let's say, for example, Alzheimer's and frontotemporal degeneration, in order for it to be probable, there has to be evidence from genetic testing that there's a mutation that the person exhibits, or family history. So in other words, someone's parent, grandparent had one of these disorders. Lewy bodies. So probable would mean that the person exhibits fluctuating cognition with alertness, I think is the rest of that, visual hallucinations, or they have Parkinson-like symptoms that follow cognitive decline. So this is what differentiates Lewy bodies from Parkinson's. In Parkinson's, the person has Parkinson-like behaviors, physical attributes before the cognitive decline. In Lewy bodies, it's reversed. They have the cognitive decline first, followed by Parkinson-like behaviors or movements. Vascular disease, which is just a stroke. It's probable if there's some kind of neuroimaging that was done that shows evidence of a stroke or what they call is somebody is with a P injury, and I can't remember now, refers to an organ. Or that the dementia is related to a cardiovascular event, or both, so that there's neuroimaging evidence and the cognitive decline occurred around the time of the cardiovascular event. And then lastly is Parkinson's disease. It's probable, if there's no other mixed etiology, in other words, there are no other types that are likely, and again, the Parkinson-like behaviors or movements occurred before there was a cognitive decline. Now, this is not a complete list of neurocognitive disorders, because there's neurocognitive disorder due to HIV or prion disease or substance use. These are just the 5 that have the probable versus possible piece of the diagnosis. And then, so here are the types. So now we're on the 3rd part of the diagnosis, and these are all the different types. So again, we just talked about probable versus possible with Alzheimer's, frontotemporal, Lewy body, vascular, and Parkinson's, but there are several others here. And then lastly, here are the specifiers that get tacked onto the end of a diagnosis. So if somebody has a major neurocognitive disorder, then you would add the severity, whether it's mild, moderate, or severe. And so does a person have difficulty with their instrumental activities of daily living, such as doing their mail, balancing a checkbook, household chores. Moderate, so are they having difficulty with more basic ADLs, such as bathing, toileting, feeding oneself? Or severe, are they fully dependent on someone else for all of those tasks? And then the other piece that can be added refers to behavioral or psychological disturbance, which is major, if somebody has a major neurocognitive disorder, or simply behavioral disturbances if the individual has, if the person has a mild neurocognitive disorder. Now, the symptoms really overlap. I have yet to find a substantive difference between what constitutes behavioral or psychological versus just behavioral, except for the fact that now with major, for example, with a major neurocognitive disorder due to Alzheimer's disease, clinicians would code a separate number for each type of disturbance. So for example, anxiety has one, so it would be FO, can't remember if it's 7 point something or other. So things have changed a little bit recently in the DSM. So here are some examples then of what a diagnosis might look like. So again, really long, but you start out with major or mild neurocognitive disorder due to possible or probable, if it applies to that particular disorder. And in this case, Alzheimer's disease. And because it's major, we have to add a severity. In this case, it's moderate. And then lastly, the behavioral or psychological disturbance. And so here's what I was saying. You can specify each one with Alzheimer's. So in this case, with agitation and with other behavioral and psychological disturbance. So something else that's not covered in the list. Here's another example, a mild neurocognitive disorder, probably due to vascular disease without behavioral disturbance. Let's see. Major neurocognitive disorder due to possible frontotemporal degeneration, severe. So we have severe in there because it's major. And then we have with mood symptoms and with psychotic disturbance. So that's what a diagnosis would look like. I didn't put any of the recording numbers in there, but you kind of get the idea of how they're worded. All right, so some of the unique needs and experiences of LGBTQ plus people with dementia. and we'll talk some about their caregivers as well. So first, I want to introduce you to something called minority stress theory. And a minority refers to any minority. Usually when we talk about minorities, we think about racial and ethnic minorities. But in this case, a minority is anyone who falls within a social minority category. So people of color, people not of European descent, women, LGBTQ people, children, older adults, people who don't identify as Christian, people who are immigrants not born in the US, those kinds of, so minority in that kind of way. So when it's applied to LGBTQ people, then minority stress it comes from stressors from hostile, homophobic, biphobic, or transphobic cultural, social, and institutional structures. So essentially the discrimination and prejudice that an LGBTQ individual feels disproportionately impacts their mental health. And so there's a connection then between coping with this marginalization and the mental health that someone experiences. So, research has shown that certain cognitive experiences, things that impact the brain, our brain functioning, can precipitate or contribute to dementia later in life. And so it's possible that the psychological stress that an LGBTQ person feels puts them at risk for discrimination later. And so you're going to see some quotes throughout the rest of the presentation. One person said, and not related to dementia, but was quoted as saying, that's an exhausting thing to deal with, discrimination. And it is, and lots of folks have experienced discrimination for different reasons. So here's just a little map then of, we start out with minority stress, and it leads to health disparities and healthcare disparities. So you've got anti-LGBTQ discrimination, which leads to physical and mental health problems. That's internal to the person, and then the external is they experience discrimination in healthcare, healthcare access, cost, and quality, all of which internal and external lead to their negative physical and mental health outcomes. So again, some of these quotes came from different articles that captured research participants' thoughts about LGBTQ participants' thoughts about accessing healthcare. And so one concern, at least by this person, was, what kind of reception am I going to get? Somebody else said, every time you go to the doctor, it feels like a risk about what's going to happen. What reaction are you going to get? So here's a quick diagram that shows the health outcomes for heterosexual or straight people versus lesbian, gay people versus transgender people. So you see that heterosexual and cisgender people have the greatest health outcomes, followed by transgender people, followed by lesbian and gay, bisexual people. And so one person said, I've used substances in the past to try to deaden the pain. Sometimes this has been a direct action after suffering as a gender minority and being treated as if I do not have value. So there's a cost to being discriminated against and being subjected to prejudice and stigma. Some people were turned to substances to make themselves feel better, and that just leads to a substance use problem. Here's another way to look at it. Percentage of folks diagnosed with depression. So you see at the bottom, straight or heterosexual people have the lowest prevalence rate, 18.9, all the way up to the top, bisexual people experiencing considerable number of bisexual people experiencing depression, nearly half, 40%. So that's quite a bit in compared to straight heterosexual people. Okay, so how many people are we talking about in terms of LGBTQ people affected by dementia? So estimates are there's 9 million LGBTQ people in the US. And anywhere between 1.1 and 1.5 million of those are 65 and older. And that leaves us with approximately 350,000 then LGBTQ people living with dementia. So here's an infographic that came from the Alzheimer's Association webpage. This is some work that they did with SAGE, which is a national LGBTQ plus aging organization. I'm not going to go over everything on this. We're going to talk a little bit more detail about other unique needs, but you can look at that and find that online. So some of the risk then for dementia in LGBTQ plus people. So they exhibit risk factors more so than heterosexual people. So depression, smoking, obesity, things like that are risk factors for dementia, and they experience more of these risk factors. There's a greater risk of cognitive impairment among LGBTQ people. Here's one research example: 18% of trans folks over 65 have dementia, compared to 12% of cisgender, non-transgender people over age 65. Again, this may be due to LGBTQ people's exposure to discrimination and marginalization. The fact that HIV tends to be more common among gay and bisexual men, and HIV can lead to dementia. Those who are African American, Hispanic, HIV positive, male, or identify themselves as some other category of sexual or gender minority also have more cognitive difficulties. So you can see some of the intersectionality, the overlay between identities. So one researcher said it's important that research and care efforts consider how gender, race, ethnicity, class, sexual orientation, and HIV status may intersect and influence dementia. So again, we can't just look at one factor. We have to look at all of them. So, so think about how LGBTQ older adults with dementia are stigmatized. They're stigmatized for each of those three domains, but what happens when they overlap? What happens in the center there as a person who is older, identifies as LGBTQ, and has a cognitive problem? And then what happens if you overlay other things on identities on top of that? What happens if this is also a person of color, or a person who has a disability, or someone who doesn't identify as Christian, or someone who is an immigrant? We have to think about all the different identities that a person brings to us when we as clinicians are working with them. So some of the things that we might see in LGBTQ adults with dementia, they may be resistant because of the anti-LGBTQ experiences they had earlier in life. So they might mistrust healthcare providers and other professionals. They may be reluctant to disclose their identity or their significant relationships. Transgender people might be uncomfortable when receiving bodily care, depending on where they are in their transition process. Persons with dementia in mid to late stages might not be able to not come out or may not even be able to manage their own LGBTQ identity. And then there's always the risk for isolation if the LGBTQ person is not able to socialize with other LGBTQ people. That's a major part of their life. So those with dementia might be are typically those who are younger, more ethnically diverse, under more financial strain, and caring for others not in the home, compared to heterosexual caregivers. Caregivers might, especially if their partner is the one with dementia, they might feel a sense of their own loss of their own LGBTQ identity. We have to think about historical context. What have these folks experienced, over 70, 80 or more years of their life? They have control over their disclosure, or in some instances, they may not have control over their disclosure. They're facing heteronormative or cisnormative attitudes among providers. So providers who provide services as if heterosexuality or cisgender identity were the norm. These providers might not have a family living with them or a family to turn to, less reliance on their loved ones family support. They might be reluctant to utilize services related to their sexual orientation or gender identity. And they too have experienced depression, victimization, stress, or discrimination in their lifetimes. So what does this all mean then? First, you're going to hear me use the term LGBTQ plus affirming. And so thinking of where we've come, you know, we're no longer talking about being tolerant or accepting of LGBTQ plus people. You know, we used to hear about something being LGBTQ friendly or maybe even LGBTQ positive. It's like we're moving closer towards being LGBTQ affirming. And so being affirming means that the person's sexual orientation or gender identity is not just tolerated or accepted, but it is really valued by others. In this case, let's think about healthcare practitioners. Affirming, so not shying away from, embracing, valuing their LGBTQ plus patients and clients' identity, sexual or gender. So here's some kind of basic nuts and bolts for practitioners. And this comes from a document you can get online providing inclusive services and care for LGBT people. So let's look at a few of these here on the left. When addressing new patients, don't use pronouns or gendered terms like sir or ma'am. And that's a big thing in the South, right? It's whenever we talk to somebody, especially someone new, somebody unfamiliar to us, we say yes sir, no ma'am. Instead, you might just say something, how can I help you? Let's see. Politely and privately ask if you're unsure about a patient's. Again, they use the word preferred, that needs to be taken out, about a patient's name or pronouns. So you can ask them behind closed doors, you know, what name or pronouns do you use? I want to be respectful. How would you like to be addressed? This is something that ask respectfully about names if they don't match your records, especially for insurance purposes that might have used government issued ID. Yeah, just asking the person what other name might it be under, instead of saying, well, what's your real name or what's your legal name? The name that a transgender person no longer uses is referred to as their dead name. You would never call somebody by that name. It's when you do so, it's called dead naming. It's very offensive. So we only say that name when we absolutely have to. Let's see. Only ask for information that's required. Don't ask just because you're curious. And then lastly, if you make a mistake, apologize and don't dwell on it. Don't keep dragging it out. Just say, I apologize that I used the wrong pronoun, or I apologize that I misnamed you or misgendered you, and then move on. You know, don't dwell on it and make it a big deal. And so here's somebody who was quoted in research. They were still calling me by the wrong name in front of the rest of the waiting room. So somebody was dead named. And, you know, for somebody who has transitioned, who for all intents and purposes pass as, let's say, a male now, if you go out to the waiting room and you ask for a Brenda or a Sue and a man stands up, I mean, how terribly embarrassing is that for the individual? So here are some other quick things you can do about avoiding gender. For example, instead of referring to someone's husband, wife, boyfriend, or girlfriend, you could simply say partner or spouse until the person says wife or husband or boyfriend, girlfriend. Instead of using Ms., Mr., or Mrs., and again, I know this is a big thing in the South, you can start with the person's first name or last name and then ask them, you know, I'd like to be respectful. Do you use an honorific like Ms. or Mrs. or Mr.? You know, what they prefer. And then, you know, don't use sexual preference, refer to sexual orientation or identity. So I'm not going to read the boxes on the right in their entirety. That's what you have the PowerPoint for. I'm just going to kind of go over these really briefly. So what you're going to see here are 10 competencies that were recommended by an expert in the field, Dr. Fredrickson, Goldson, and their colleagues. They publish a lot on this issue. So first, they talk about being competent in attitude, because our attitudes influence the care we give to LGBTQ people. And as I mentioned before, understand the historical context as well as the social and cultural context. And here, because the past experiences that someone has had may alter what they need or how they behave. So again, not wanting to disclose because, maybe in that generation, we didn't talk about one's sexuality, or that person lived a life in the closet, not disclosing. So we have to think about the generational context there. This is intersectionality again. So remember that the person we're seeing is not just one category. They are comprised of lots of categories. So I'm female, I'm lesbian, I'm cisgender, I'm half Italian, I'm half Irish. I'm from the North. I mean, all of these, I'm white, middle class, all of these things make up who I am. So develop a tailored and responsive care strategy based on those person's many identities. Make sure that you're staying up to date on culturally competent practice. And nowadays, we're not even using the term cultural competence. We talk about cultural humility. So again, trying to stay on top of all of these new terms is a challenge, but something we must do. Of course, we use empathy and sensitivity during assessment and interviews. Make sure that we're using appropriate language with the individual. So the person's relationships may have changed as they've developed dementia, and they might not be easily teased out, except maybe through an informant, again, a collateral, a family member, or a friend. Caregivers. LGBTQ people do not always have a family of origin to rely on, especially if they have been rejected at some point in their life. So in that case, we talk about families of choice. And so expand your definition of what family means, because those are going to be the individual's caregivers. So we need to help them help the person, and the caregiver may or may not be LGBTQ themselves. So what does it mean for a person who's not LGBTQ to be caring for somebody who is? They might not know what resources are available for their LGBTQ friend or loved one. And then, of course, environmentally speaking, we want to create a welcoming, affirming, and supportive environment. And you can get resources online for, how to incorporate language and visuals in your practice. A rainbow pride flag goes a long way in cueing the individual that it's a safe environment, if in fact it really is. Understand how local, state, and federal policies and laws affect the LGBTQ individual and the caregiver, or even the care that you provide, things that address capacity, decision-making, and consent to advocate on their behalf. And then lastly, we need to help the LGBTQ people affected and their caregivers navigate care systems and advocate for innovative approaches on their own behalf to get the care that they need. And then I thought this was a great quote in one of the articles. If you observe other healthcare providers discriminating or treating a patient or support person with anti-gay bias, just stand up and stop it. We in the majority will hear things that we let go because we're too uncomfortable to say anything, or because of who said it, or it's not my place, or we'll just think bad about the person who said it. But things don't change unless somebody stands up and says something. So yes, you have to pick your battles, but if you think it's appropriate to do so, if you feel safe in doing so, then pull somebody aside and say, not cool, or ouch, or what you said really affected me because. Here are a few resources that I pulled together for LGBTQ people affected by dementia, whether those are care recipients or caregivers, and some resources for professionals who care for them. If you have anything that you want to talk about, I'd be happy to chat further by phone, by email, or we can set up a Zoom. And then if you're interested in reading more, I provided the references there. So I know that I went really, really quickly. I appreciate you sticking with me. I am happy to stay and answer questions past 1 o'clock if Ellen is okay with that, or if we do have to go again, I'd be happy to talk via email or phone. So thank you everyone for being here. I hope you got something out of the presentation. I appreciate your time.
That was a fantastic presentation. I feel like I've learned so much, and I feel like we all benefited from that. That was so informative. Thank you so much, Dr.
Thank you.
Maccio.
You're very kind. Thank you.
So I will give everybody a couple minutes. If anybody has any questions, feel free to put them in the chat and we will go through them. A few thank yous in the chat already.
Great. Thank you.
I think one question I was kind of wondering too while you were speaking is as professionals, if we really want to get started on making sure that the place where we work is the most up-to-date that we can be on all the information related to things you shared today, where would you recommend we go? Or as a caregiver, where would you recommend we start?
Yeah, that's a really good question. GLMA, which used to stand for Gay and Lesbian Medical Association, has some great resources for providers. They might speak a little bit more to physicians, but they are certainly applicable to others. And then there's that other one. I'm forgetting the name of it, but it was. Let me find the name for it. There was a picture of the cover. Let's see. There it is. There it is. It's called Providing Inclusive Services and Care for LGBT People, a guide for healthcare staff. And let me see if I can read the fine print on here. Let's see. Oh, it's not what I wanted. Here it is. National LGBT Health Education Center. It's a good resource. Yeah. And then SAGE, which is now the National Resource Center for LGBTQ aging or something like that. SAGE also provides good resources as well. So those three in particular, if you Google LGBTQ affirming care, or how to LGBTQ affirming care, you'll get resources that will tell you. I mean, some basic things are, do the intake forms include genders outside the male-female binary? Does it allow somebody to identify as transgender? Well, it used to be adding relationship status instead of marital status, but now that there's marriage equality, it's less of an issue, but still not everybody's married. So are there options there for people who aren't married? Are there visual images? So are there posters, brochures, flyers that depict same-sex couples, not just opposite-sex couples? Are there magazines or books in the waiting room that are geared towards LGBTQ people? So like, for example, not that I'm endorsing this, but there's a magazine called The Advocate, not to be confused with the Baton Rouge Advocate. That's a premier LGBTQ publication, that or Out magazine. might be a good addition. Again, any kind of pride flag image, whether it's, even just a tiny pride flag stuck in somebody's pen and pencil cup, or a little sticker on the, sliding glass window, or even something that says everyone welcome here. These are little cues to LGBTQ people that this is going to be a safe space for them. So hopefully that translates into actual care, and it's not just a sticker that somebody has. So they don't, unwittingly disclose something intimate with a care provider who's not willing to hear that.
Thank you. That's so helpful.
Mm-hmm.
One thing also I really took from this presentation too is I really appreciated your consistent reminders as well. There is so much to learn, and everybody doesn't know everything, and it's okay to learn and approach it with the best knowledge that you can. So I really appreciate that, because I think it can feel overwhelming sometimes with the amount of information that's out there that's accessible. So thank you for that too.
Absolutely. There is a lot of information out there, and it is a challenge to stay up on it all. And I make mistakes myself. I misgendered somebody last year, the year before, and I still cringe when I think about it. I mean, I think, I teach classes on this at LSU. I give presentations like this, and here I am misgendering somebody, and I was mortified when it happened. I apologized. I engaged in self-flagellation for days afterwards. I mean, it happens. But you learn from it. The best I could do is just do better next time. I mean, that's all.
Absolutely. Well, thank you so much. I don't see any more questions coming through the chat. We have a lot of comments. Thank you saying how this was such an excellent presentation. I've saved all of those for you, Dr. Maccio.
Oh, thank you. Appreciate it.
And just a huge thank you again for taking the time out to share this information with us. And thanks to everyone who joined us today. And if you think of any questions, like Dr. Maccio said, her contact information will be included. So you can always message her and get feedback from her that way as well.
Yeah, again, Ellen, thanks to you for the work that you do as well. And thanks to you and Alzheimer's Services. I'm so grateful that you're here in Baton Rouge, and it was really wonderful being here today. And thank you to everyone who came.
Thank you so much. Appreciate that.
Thanks.
Everybody have a good afternoon.